Hi, my name is Sean Millard. Today's date is April 4th, 2020. So, in the unit 4 case connections, case 1, there's lab panels ordered to determine metabolic disorders occurring in the patient. The patient is a newborn infant, so it's important to focus on newborn metabolic disorders when you're determining the diagnosis and treatment. And you also want to find a lab panel that will be able to determine both urea cycle and beta oxidation cycle disorders, not just one or the other. So, to get down to it, I chose urinary acid panel as the correct choice to determine between both. This is because there are very high amounts of orotic acid in the urine in the patient. Urine would also show increased ammonia, which would be hyperammonemia, which is consistent with urea cycle disorders. The excess uric acid will not be synthesized in the body, therefore it would be excreted as waste in the urine. Uric acid accumulates in the cytosol when there is an increase in the carbamoyl phosphate being produced. This is the carbamoyl phosphate is the substrate needed in pyrimidine synthesis. Since there is highly elevated levels of ammonia, the enzyme carbamoyl phosphate synthetase 1 will use ATP from the liver and glutamine, which is an amino acid, and they will be combined with the allosteric activator, the N-acetylglutamate, which will produce carbamoyl phosphate. Since the liver is providing ATP in this process, you can rule out that there is any issue with beta oxidation. The high levels of ammonia will make carbamoyl phosphate extremely abundant and in excess with the mitochondria. The ornithine carbamoyl transferase enzyme, the OTC, as it's abbreviated, will combine with the substrate ornithine and carbamoyl phosphate to create a citrulline. Citrulline is created in the cytosol. This process happens in the mitochondria, though, during the urea cycle. Since there is the deficiency in the OTC, this would explain how the patient has high excess of carbamoyl phosphate, which will lead down the road to excess orotic acid, which is excreted in the urine. This would also explain the lower levels of citrulline, where they're not extremely low, but they're definitely lower, and that would also explain the deficiency in the OTC enzyme, as in it's having deficient problems in transferring the substrate ornithine as well. So, the blood glucose panel would not be efficient in determining both beta and urea cycle deficiencies. A blood glucose could determine if there is beta oxidation due to disorder in hepatic function in the liver, but it would not explain the elevated levels of ammonia, as ammonia comes from urea, which comes from arginine being cleaved by the arginase enzyme in the urea cycle. There could be, for example, hypoglycemia, which would cause a reduction in acetyl-CoA, which would inhibit the urea cycle through beta oxidation, because it would reduce the amount of ATP being used, but it wouldn't really explain the levels of ammonia, which are also common in urea cycle disorders. The serum fatty acid panel, it would be incorrect, because it can be used to determine hepatic disorder, but it really wouldn't show anything that has to do with the urea cycle, because fatty acids can be involved in things like obesity, insulin resistance, which is associated with different types of fatty acid circulation in adipose tissue in the liver. The liver breaks down fatty acids in a process called glycolysis, and this is where beta oxidation comes in. Beta oxidation in the liver from fatty acids produces acetyl-CoA. So if there was a problem here, it could reduce the urea cycle, but it wouldn't be able to distinguish if there was a problem between the urea cycle and beta oxidation because it wouldn't explain the elevated levels of ammonia. And finally, there's the plasma glutamine levels. This would be incorrect because glutamine is combined with 3 molecules of ATP and used by the enzyme carbamoyl transferase 1 to convert ammonia into carbamoyl phosphate. This panel is relevant to the urea cycle, but orotic acid comes from the production of carbamoyl phosphate. There are elevated levels of orotic acid in the patient, indicating that there is no deficiency in glutamate because the process that involves glutamate is obviously in abundance. So this wouldn't explain, this wouldn't really show the correct deficiency here in this patient. So the one urea cycle enzyme that's most likely to be deficient would be the OTC enzyme. As I explained earlier, it synthesizes ornithine and carbamoyl phosphate to create citrulline. There's an abundance of ammonia, which means carbamoyl phosphate is being produced. Since the carbamoyl phosphate is not being synthesized with the ornithine by the OTC, the excess carbamoyl phosphate is being excreted in the cytosol, where it can cause an elevation of orotic acid. And this also can, lead to a deficiency in an enzyme called the orotate phosphorybosyl transferase enzyme, which is involved in pyrimidine synthesis. But we don't need to go into much detail about that. The most least likely deficient enzyme, I think, is the arginosuccinate synthase enzyme, or the arginosuccinate lyase. Lyase one cleaves, and then the synthase one takes the citrulline and converts it down through the cytosolic urea cycle. The arginosuccinase will be cleaved. Arginosuccinate will be cleaved by the enzyme arginosuccinate lyase to create arginine and fumarate. Arginosuccinate synthetase will synthesize citrulline with aspartate or aspartate to create the arginosuccinate, and then arginine is converted into urea through the enzyme arginase. Urea is converted into ammonia, and we know there's extremely high levels in this patient. There's even a really high spike. And since there's lower levels of citrulline in the blood and high levels of ammonia, these two levels are consistent with OTC enzyme deficiency. Alright, so for case 3, this patient has a diagnosis of gout. The patient has significantly decreased urinary uric acid levels and increased urate plasma. Multiple causes for gout, so you need to be careful when you're diagnosing the root cause of the gout. So first, to explain, gout is a form of arthritis that is caused by the crystallization of uric acid deposited on soft tissues and joints throughout the body, and it can cause severe pain, tenderness in patients, and is often associated with redness and swelling around the affected areas. So to eliminate other causes, or other common causes of gout, at least, overproduction of purines, this would indicate the patient would have a disease called the von Guericke's disease. This disease happens from overproduction of purines, and the result of that is hyperuricemia, often occurring in a deficiency in the glucose 6-phosphatase enzyme. This would increase synthesis of ribose 5-phosphate substrate, which is the precursor for PRPP. An increase in the 5-carbon sugar PRPP would cause an increase in purine synthesis, leading to a cause of total plasma urate levels to increase. In humans, we catabolize purines to uric acid. So this diagnosis would not explain the decreased urinary uric acid, because there is an increase in purines in this disease, meaning there would be an increase in urinary uric acid levels as well. Decreased salvage of purines. This is consistent with a Lesch-Nyhan syndrome, which is a result of overproduction of hyperuricemia. This can be characterized by episodes of uric acid lithiasis, which is uric acid stones, self-mutilation. indicating a deficiency in the enzyme of purine salvage, which is hypoxanthine guanine phosphoribosyltransferase transferase. The Lesch-Nyhan syndrome is consistent with the overproduction of uric acid in the body due to an increase in PRPP, which results in purine overproduction. The uric acid levels would be extremely high in this syndrome, and it's not indicative in the patient who has very low urinary uric acid levels. Also, this is a very rare disease, and the diagnosis usually occurs earlier in life. The patient is close to his middle ages. Decreased urinary excretion of uric acid. So this can be consistent, and this is something that falls into what the patient has, but it doesn't really give us enough information to determine the cause of why the patient has decreased urinary excretion of uric acid. So decreased urinary uric acid can be caused by excessive alcohol consumption. This is one thing. Ethanol ingestion can increase serum urate via a decrease in urate excretion and increased urate production. Reduced excretion of urate can occur because of lactic acidemia, which is lactic buildup due to low pH in the bloodstream. This is caused by alcoholic consumption. It's caused by a lot of other things too, but in this case it's caused by alcoholic consumption. The decreased rate of uric acid excretion will cause hyperuricemia. For this to be determined as a cause, like I said, you would need to know more about what is causing the increase in the plasma urate, as well as why there is a decrease in urinary excretion of uric acid. Does the patient consume alcohol? Does it say the patient consume alcohol? There's other causes too. You may also need to know if there's any kind of kidney or renal disease, a thyroid disease, or any kind of medications that can decrease urinary excretion, or more specifically, urinary excretion of uric acid. Kidney stones and things like that can cause blockage. So it can be, this can be associated with many different things. One thing that we probably need to do here is check for the renal levels of the patient. You could determine maybe if there's some kind of kidney problem or if the decreased urinary output comes from something else. But there's just not enough information here to really determine that. So, following that, additionally, it's stated that the patient switched their diet of diet soda to regular soda. The patient states that they drink 4 to 5 liters of soda a day, which is generally 4 to 5 regular sodas a day. Soda, the primary sugar is fructose or high fructose corn syrup. We know it's not good for you. It's very consistent with things like diabetes, which I'll get into. The addition of fructose to the diet can impact the potential of gout by inducing uric acid production. Fructose does this by increasing ATP degradation to AMP, which would also cause a substantial increase in serum uric acid levels because AMP is a substrate used in uric acid production. The very high amount of fructose ingested daily by the patient will cause a high uric acid production and cause hyperuricemia. This is consistent with elevated levels of plasma urate and a decrease in urinary uric acid because the high fructose consumption leads to things like risk of diseases associated with hypertension, chronic renal disease, and also can cause things like diabetes as well. The chronic renal disease definitely could explain a deficiency in the kidneys of the patient, which would very well explain the decreased levels of urinary uric acid.